Good afternoon. Good evening. My name is Usman. I'm currently working as internal medicine trainee at Frimley Park Hospital. And I have my other colleague, Mustafa Aziz, with me. He is also one of my colleague. We have both worked together in doing this project, which we work together on seeing how to improve the care of MINOCA. And this was a single center retrospective cohort study in Frimley Health NHS Foundation Trust. Um, so, just a brief definition about MINOCA. MINOCA means myocardial infarction with non-obstructive coronary arteries, a patient who comes in with chest pain and elevated troponin without any significant blockage found in an angiography. Um, so it is a very complex diagnosis, and it's quite challenging to find out the cause for raised troponin. So it is also defined as because of despite lack of obstructive coronary artery disease, there is an insult to myocardium. So this slide, and then we can see there are different heterogeneous conditions which are also associated with MINOCA. For example, there are vasospasms, a thromboembolic mechanism, plaque rupture, plaque erosion, or coronary microvascular dysfunction. So our focus for this QIP was to make a pathway so that we can facilitate more accurate identification of MINOCA patients and to tailor the investigation and diagnosis. But there were a lot of diagnostic challenges and management challenges because of lack of clear guidelines in our trust. Just a brief slide about causes of MINOCA and what could be the mimickers of MINOCA. We know atherosclerosis is the main cause of MI, and specifically plaque rupture, plaque erosions, and some calcified nodules can cause obstructive coronary artery diseases. There are other mechanisms such as coronary microvascular dysfunction, which and or other non-atherosclerosis causes like spontaneous coronary artery dissection, embolism, or vasospasm. We also have to consider non-ischemic mimics, which are Takotsubo, myocarditis, and they are very challenging to differentiate, and we have to go to next step of imaging to either differentiate between two. So because of this diagnostic complexity, we identified problem, and we went ahead to collect the data, and we identified the gap. So the data will be presented by my colleague. I think Mustafa, you are mute.
Hello, everyone. The data we conducted our study across the two acute hospital sites. We included a total of 976 patients across Frimley Park Hospital and Wixon Park Hospital over a 6-month period. So we categorized patients according to presentation with chest pain, plus or minus ECG changes, and if they had trop rise, then they would fit the criteria for MINOCA. If they didn't have any trop rise, then or troponin was normal, then it would be INOCA or ANOCA, which is ischemia with normal or non-obstructive coronaries. We excluded patients during our study, those patients had their coronary angiography either as part of workup for other procedures like interventional surgical intervention, like aortic valve replacement or bypass grafting, or patients who had normal coronaries, but they had previous stents. Next slide, please. These the so this table shows how we categorize patients when we reviewed their coronary angiographies. Like we explained previously, so these patients were either MINOCA or ANOCA. These were on the left hand side were the diagnoses that were given to these patients at the time of, or either before or at the time of the coronary angiography. Many of the patients were labeled as myocarditis, pericarditis, myopericarditis, or supracardiomyopathy. Some patients had a diagnosis of dilated cardiomyopathy, but the most interesting bit was that the highest number of patients didn't have any diagnosis at the end, even after the coronary angiography. So some of them, 39 patients who fell under the criteria of MINOCA, didn't have a diagnosis, and 56 patients who fell under the criteria of ANOCA or ischemia with normal coronaries or non-obstructive coronaries didn't have a diagnosis in the end, even after the coronary angiography. And from this bit, we identified the gap that those patients had or didn't have a final diagnosis, or that would allow further follow-up or further treatment or characterization of how they presented, and the treatment needed. Next slide, please. So in total, the MINOCA and ANOCA patients were 317 patients. So part of the follow-up plan for these patients were the most important here would be a cardiac MRI. So it was planned for 59 patients across both groups, the MINOCA and ANOCA. Uh, Cardiac MRI was done in 50 of these patients. There were other investigations like transthoracic echo Holter and CT. So these in total were six patients. The follow-up of all patients, of the 317 patients, was 103 patients only had follow-up to follow the treatment and the result of the investigations. Next slide, please. So the problem here, or identifying the gap, was when we were screening those patients and their coronary angiographies, we identified that there were some invasive investigations that were essential in the diagnosis or characterization of the diagnosis of these patients, like intravascular ultrasound or OCT. Which are mainly intracoronary invasive investigations. There were minimal use of these investigations, as well as the cardiac MRI. There were no clear plan or no clear criteria to the use of these investigations. There were, of course, there were delays in ordering or performing these investigations, as we explained. Some patients were planned to have cardiac MRI, didn't have this investigation, neither did they have any follow-up. So again, this is in the overall picture of not having a standardized or a formal pathway for those patients who meet the criteria for MINOCA. So they presenting as myocardial infarction, and when we do a coronary angiography, we don't find a clear explanation to the presentation as myocardial infarction, and again, which falls under this. In this category, there was no sufficient workup to diagnose these patients, and like a structured plan for the follow-up, or like for the treatment and follow-up. Next slide, please.
So what we did, we identified the gaps, and in order to implement changes for MINOCA care, we made a diagnostic algorithm in where we can incorporate the cardiac MRIs. We made some certain indications, and we standardized the follow-up and making sure that the schedule and patient education materials are also handed over to patient. This is slide about the ESC MINOCA pathway. There's a clear pathway on an ESC which suggests how we should proceed ahead in patients who are MINOCA. But because due to logistic and because of NHS being under pressure, we formulated and discussed this in our multidisciplinary team cross-site meeting, where all of the consultant then formulated a plan and helped us in identifying where we can make some changes and where how we can help developing a more improved version of pathway in our institute. The limitation of this study were that the data did not include the IVAS or OCT performed, and it also showed a limited number of investigations. We are planning to include these in our further cycle in future. So this is our pathway, which we have presented, and patient were coming with invasive MI with raised with clinical history suggesting of chest pain and MI ECG changes, and they have elevated cardiac enzymes. They will undergo invasive coronary angiography, and if they have less than 50% stenosis, we would consider known coronary causes. We'll see if the history and other things suggest if there are known coronary causes like pulmonary embolism, tachyarrhythmia, Takotsubo, or if the patient is on cardiotoxic medications, or sepsis is one of the most common driver of type 2 MI. And we can consider an echo or laboratory investigation like BNP to facilitate our diagnosis. If it is, if any of such cause is present, then we'll label it that this is not a MINOCA case. And if still MINOCA is a working diagnosis, one of our intervention cardiologists will re-review the angiogram um, to look for any SCAD and coronary thrombus. Um, and then for further workup, they will need cardiac MRI. And due to the logistic and because of the CMR time frame, we took over hospital guidelines regarding inpatient cardiac MRIs. So for because CMR cardiac MRI needs to be done within 14 days of event for the best reporting and best view of the myocardium. So we decided that we will go accordingly to the troponin level. If troponin rise is more than 660, and this number and data were driven after reviewing the literature, and there is a certain guideline in our trust for which patient inpatient cardiac MRI should be done, and those patients were started on dual antiplatelet. Um, and then further patients were also will be considered for IVAS and OCT if they are prepared to look for any plaque rupture, coronary embolism or thrombus, and also an echo to look for any PF or PFOs. The main headlines was to develop this pathway was whether what we should do in when we are going forward, whether we should treat those patients with the with the cardiac medications, or we should just continue investigating further. So MRI, if it shows that there was a ischemic pattern, then the dual antiplatelet and triple three pillars of medication post myocardial infarction would be continued. And if it is a non-ischemic pattern, then Takasubo, myopericarditis, or non-ischemic cardiomyopathies would be the differentials, but the MRI would suggest that what the base of diagnosis is. Um, but we included, there is a small slide but you can read that it should be included if diagnosis clinically suspected. When patients are being discharged and the suspicion is myopericarditis or Takasubo, then we would include that based on high suspicion and imaging. Um, and if diagnosis is still not clear, the functional assessment studies, ESC's guideline says that you should do the functional assessment studies while during the process because of increased cath lab time and an increase and then because of pressure and NHS being overburdened and huge waiting lists, the consultant thought that they would continue if still the suspicion of MINOCA is there, they would then do the assessment. And that concludes our presentation. If there are any questions, please you can ask. We are happy to answer them.